I have something to show you here. I want you to be. Can you just put this scan for a minute in the center? This is very important about this progression. I think this works the same way here also in every topographer, but it's important. This scan, can you do it here in the center? You can't get it here? Okay, doesn't matter. See, fantastic, because this is very important. It's a good map, and thankfully they got it. So let's assume this is a progression map, and you see that this area is 0.4, 0.5, kind of bordering to your repeatability range. Interesting is, for the sake of people sitting in the back, the pachymetry has dropped by 17 microns out there, and but this is a 0.4. So how do you, the first thing which you look at is that pachy has changed. You can see the difference mapped by 17 microns. But the challenge here is, if you just put the cursor somewhere here, you also, when I see the pachymetry, I also look at the X and Y coordinates. I want Professor Randleman to comment on this. The X and Y coordinate of what I took on the time the patient came to me first time to the second time, it's differed by around 0.50 microns. Do you think that would make a difference? Because you have changed where you are looking at as the thickness. The thickness, XY is your coordinate in the center of the pupil where you are having your thinnest point. Your thinnest point has shifted based on your scan from the time you took the first scan to the second scan. Do you think this is important? Because you can see the difference is here, 0.50 is on the x-axis. It's significant difference.
But Rohit, look how the pupil has changed regarding during the two measurements. So those measurements are not reliable measurements. You cannot compare those two measurements because there must be a measurement error. It was misaligned or something. So that 0.5 does not respect the fact that you may have not aligned measurements.
Exactly. So this is what I wanted to bring it up in this case. I'm thankful they got it out. This looks like a small progression. And the pachymetry dropping by 17 microns. But always look at your XY. It means that the first time was not aligned or the second time is not aligned. And these patients are ones who always end up in having some controversies about should I do a cross-linking or not, because sometimes we see that there is a suspicious progression, but the complete pachy has changed. Pachymetry, when you do a comparative map, has to be looked always when you're using a pentacam in relation to the XY coordinates. If the XY coordinates are not matching or they're close to each other, then probably you are actually looking at the two different references.
Pachymetry also has the most variation due to diurnal fluctuation. We all know the cornea is thicker when we first get up. So if you see one patient sometime at 7 in the morning or 7:30 and let the same patient another exam at 4, there will be noise in that. Can I just quickly show, I want to show a couple quick things. This is an example of what I was talking about. This is a 15-year-old with 13-month follow-up. If you notice, I've enlarged the Kmax. The Kmax on 3 exams over 13 months was 46.1, 45.5, and 45.8. So again, shows no real change. But if you look at the progression graph, again, we're over way past the 95% confidence interval on the posterior surface. So this is true progression in spite of Kmax. Here's an 18-year-old. We're showing both eyes. Again, stable Kmax. You'll see on the left, we just hit about the 95% confidence interval. But if you look on the right again, marked progression in spite of stable Kmax. So particularly on your young patients who we know will progress rapidly, I think relying on Kmax is not doing the patient a best service. And this is someone with progressive advanced keratoconus. The bad D is over 7. So there's no question this is fairly advanced disease. But again, if you look at the A value, which is the anterior surface, it's been relatively stable, but look at both B and C, you'll see again progression on the posterior surface and progression on corneal thickness well past, I mean, this is well past the confidence intervals that we normally would require, in spite of, you can't really see the numbers, in spite of the fact that Kmax really hasn't changed significantly.
The other question we commonly get, which we need to answer, I mean, this is one of the most commonly asked questions is, you do a cross-linking, and when do you say, I mean, people say that 0.5 to 2 diopters of any, it can grow up to 8 diopters of flattening is considered a good way of looking at outcome. I would like to ask Professor Saylor, after say 20 years of cross-linking, do you really think a flattening is the best judgment of an outcome of cross-linking? That means if you don't have flattening, you mean that it's not working.
No, I'm ready to give my talk this afternoon about those criteria, but flattening is a nice side effect, but has nothing to do with a real cross-link.
You use the word nice side effect. Is it really nice?
It could be nice, and I will show you some cases where it's really bad. We had, earlier this year or last year, we had a publication in 3 cases where we had a constant flattening for over 10 years, and then it's not nice at all, and it's considered to be a complication. But in many of the cases, if they have a 5 diopter flattening after customized cross-linking, coming at a 1-month follow-up and say, hey, I see so much better, that is nice. But it's not mandatory for getting a success. The success would be if that cornea does not progress. That is the success of cross-linking.
So this is very important here because if...
I'm sorry, I completely agree with that on an individual patient basis, but I would, and I think you'd agree that on average, I've never been accused of being too quiet, sorry. On average, effective protocols, if you look at 30 patients, 50 patients, on average there is flattening. So not on every individual patient, but if you're looking at studies that are comparing protocols, and there's a protocol, hypothetically, that's published with no change whatsoever, that's really concerning that that protocol is doing anything. So difference between individual patients and groups.
Okay, let me ask you a question, Bradley. I have 2 protocols, 2 treatments. One treatment causes marked stromal thinning accompanied by flattening. And the flattening may actually only be secondary to stromal thinning.
I want to show you this here, and then...
You don't like our questions.
See, when you talk about flattening or getting good outcome, the major issue of measuring is the haze. And when you have, I mean, somebody can just show somebody, a lot of people have not used this in the pentacam. If you just go to, you can just start from beginning to say where it comes, and you can come down and scale it. Let's forget for the minute how reliable, how repeatable it is. There's enough papers on this about its repeatability issues. It tells you the haze densitometry from 0 to around 12 millimeter. I don't know how they're going to do it, but it's there. But what is important here is, it just gives you an idea that denser this is, the poorer is the repeatability. So if I have to do my outcome measure, I try to compare this to a stage where it becomes closer to the pre-op stage. For example, if you're done cross-linking and your densitometry when you did the cross-linking was, let's look at the value of around 15, now it's 32. So when you do it on a 32, the densitometry, the machine's repeatability really goes down, and we published this in one of Indian Journal of Ophthalmology. So once, it takes around 9 months, sometimes to 12 months, sometimes 13 months for this to reduce. And once it reduces, your value actually starts coming back to the pre-op stage, and then your repeatability actually starts getting much more repeatable. So even though a lot of them don't use it, I find it extremely useful because it tells you exactly whether your repeatability of your scans are good or not, because every time there is there is these kind of, and these are not clinically there. To be very frank, you see a very clean, good eye, and you say that I've measured it clinically, it's not there. It may be an artifact, it may be something else, but at this point of time, it's matching to what I'm thinking, that it's giving you a good index of how repeatable I am about this. And when you do your smile extras, when you do it with both the eyes, it tells you if there is some density changes, definitely. And over time, you know that how it's changing. When there is one of the major issue with density, I believe, you can correct me, is not your curvature map, it's your Pachy map. So many times higher the density, the pachymetry looks artificially low. That means some people said, I did a cross-linking, and post cross-linking, I'm showing a pachymetry low of 100 microns. And once the densitometry becomes back to normal, I think it gets better. So the densitometry is probably one of the most important hidden tools for me in the machine, which you need to do when you're looking at outcome of cross-linking. Cirrus also has a densitometry, if you are trying, and this is the densitometry, but Hakim, does it give you a value, any value on this? How do you look at the densitometry?
Give only the percentage of the part.
Do you have for the cornea here?
Yeah, it doesn't have the corneal densitometry. It have the cataract densitometry, the lens densitometry.
No, not the lens, but it has some feature, but I think they're not.
No, they denote in a value.
Not uploaded.
Yeah.
Okay, for the time being, then we'll stick to this. Professor Bellin, do you think?
Yes, and that's kind of what the point I was trying to make. Ultimately, the parameter we should be looking at is best spectacle corrected visual acuity. Patients don't care whether they came in with, well, they do care if they have haze, but flattening and stromal compaction, ultimately, so the point I was trying to make, if you have a parameter that gives us flattening but has haze and patients have no improvement in vision, and another one that basically doesn't produce haze, doesn't produce flattening, but they get a line or two improvement in vision, ultimately that would be a better procedure to have. Now that may never happen.
Only if it actually stabilizes the cornea.
Yes.
But there's no evidence that there's a treatment out there that does that.
I'm not saying there is.
But there's, well, but a marked stromal thinning, I think, is not what is typically found with the standard protocol.
There's some stromal thinning that then goes back over a period of time.
Well, there's
Yeah,
some
but
thinning,
this
which
is-
is probably
this is
epithelial
post-work-
remodeling.
Wait. Are you really believing that this is a real effect? Is it not an artifact?
Which? What?
Or the thinning that goes back to normal within the first year? I mean, if you do this with ultrasound, you see some thickening after cross-linking, not thinning. If you do with a high-resolution OCT, the thickness of the cornea after 3 months is exactly preoperative. So that thing that we published in 2006 or 7, that the cornea gets thinner after cross-linking and then returning to normal after 1 year, is a classical optical artifact due to the densitometry.
We published this work that when you have a thicker densitometry, your cornea just drops down very thin. The machine, for some reason, picks up Pachy as low as 100 microns, 200 microns. I've got this many times. I did a cross-linking. My Pachy has not gone to 230. Did I burn the cornea too much? And I said, just wait for some time. And then over a month or 2 months, then you start. It's not, I think it's just related to the change of how the densitometry is behaving.
So Rohit, you say that the Pachy which you get after cross-linking is not reliable, so it's better to do an ultrasonic Pachy?
Yes.
You don't take it on its face value?
Exactly.
Yeah.
We did the, this is an IGO, I'll send you the article, that the more the densitometry, all your values, and the worst value to be affected with post-cross-linking densitometry is pachymetry.
So I have a point here, sir. So this is an image actually. This is a photograph, a Scheim fluke. So if you have a backscatter from a scar, you're not going to get the posterior elevation and the Pachy. So I tend to monitor my patients on an OCT rather than immediate.
But how do you? OCT is a great tool, but this is again for a lot of us who want some value to be seen, some colors to be seen. In fact, OCT, if you sit with somebody and develop a math software, you can actually get a much better things like this, because it's more of a clinical picture. But if you don't have OCT, and if you have just a pentacam, I think this is definitely a tool a lot of cross-linking people should be doing when you judge your outcome, good, bad, or ugly.
You could look at the Scheimpflug and look where the edge detection is. I don't know if you did that, and you can tell. Okay, there's a display where you can actually go in and get a blow up of the Scheimpflug and see where it's picking the edge detection, and you'll be able to tell if it's artifact or not. And then you can that's what you did. Okay, that's.
So the two important points, I know everything else everybody knows about it. Two important point is one, look at the pupil XY coordinates when you're looking at a progression, because this is a classic case that your XY is different, so your progression looks different, your pachymetry looks different. XY is the most important thing. And I usually mark that zone that I have looked at X and Y, because that's pupil changes your thickness drastically. And the second one, when you're looking at an outcome measure of a cross-linking, anything, I always look at the densitometry map, which kind of gives me that feeling that everything is going okay. And I'm not sure, this is a map Hakeem has pulled out from the Cirrus but it's not a densitometry map. But if you have a lot of scar, do you think that white ghostly cornea looks a little bit darker? I'm trying to find out if the other machines also have some hidden stuff like this which we can use it. Professor Saylor, do you have it? Do you know where?
With the pentacam, you can even make a profile.
No, this is on the Cirrus, sir.
Yeah.
This is the pentacam.
Oh, yeah, here we have it.
I'm trying to see. I'm trying to see if people who use Cirrus can also have some tool for them to use it. We'll try to figure out. If we find it, we'll let you know by the time we leave. Any other questions on keratoconus indices or anything? The ABCD is not, I think only some machines have it. They've not loaded it in all the machines, and there's still not the full version of ABCD, Professor Bellin, is not available to us yet. So people have not really started using it here.
The original version, what I showed you is the current version, which Oculus has had for almost a year and still has not released it. But this is the second iteration, but it has a lot more flexibility to it. But the primary one's been out for 2 years, maybe. Yeah.
Any other questions? Yes, ma'am.
I'm using the ABCD.
You're
I'm
using
using
it,
it. Yeah. It's a as I mentioned before, it's a multi-dimensional diagnosis. And if I'm looking at that chart, I see what has changed, and then go into detail and see whether this is information on the back surface is really reliable, and look at the Scheimpflug images. Like in this case, you can see, hey, that edge detection might be not exactly that what we want to have. And then we do the same thing with a high resolution OCT and find out, hey, ABCD was totally correct, the posterior surface has changed significantly, and then we trust the ABCD in this case.
So he's found something on Cirrus also, and I don't know how reliable it is, but you can go back and check. People using Cirrus, you don't get a nice beautiful color like this, but I think, can you show?
Yeah, this is a post crosslink patient, so it shows in a percentage. Like
I don't know, I've never used this, but I will definitely try to see it. And that means it's giving you a change of percentage. So if you look at it from pre-op and post-op, I think you probably get something similar to this, but I may be wrong, but we'll have to check. So basically it is there, it's hidden there, and you can probably use this. Yes, please.
Since we don't have ABCD, can Dr. Bellin just go and tell us a bit more about the bad display and the other features that we see on the bad display in cases of keratoconus, which are very early or suspect, and in case of progression? Because we don't have ABCD.
If you don't have it, then we still have to use these parameters like all of us at this point of time. And in his, he's made it easy, including visual acuity, best corrected, and all of them are included in all of them, so it makes it easy. Otherwise, we'll have to go scan by scan like what we said.
So,
But I think when you're talking about your next version of your looking at the progression index, when you see the progression stuff, probably you should also look at these kind of cases where the machine should at least warn that your pupil center taken during the first scan and the pupil center taken during the second scan were not well within the normal limits. They were completely different. Because if we don't really look at the pupil centers in these two, we would have probably missed the entire game.
But the pupil is not a good landmark. It's probably better to take something like the limbus, because the
No,
pupil...
this is the thinnest point. It's giving you the X and Y.
For the Pachy, yeah, but the pupil can be dynamic, it can
Yeah.
change. So then there's a centroid shift. So this, basically, you cannot exactly estimate. So different times, different pupil sizes, the centration can be different. So it's better to use some fixed landmark like the limbus, probably, to know if your scans are centered
yeah.
well.
More cyclotaurid or
so if I can address what I thought the person asked, and that is, if you don't have the ABCD, can you use the bad display for progression? And a lot of times I'll get a question is, what's the difference between, why can't you just use the bad display? So the bad display was specifically designed to separate normal from abnormal. It doesn't diagnose. Now granted, we can all diagnose keratoconus with it, but it's really designed just for screening normal to abnormal. As an example, now most of you will be able to tell the difference just by looking at the map, but if you have someone who comes in with corneal edema, the bad display will be worse than it was before. It doesn't mean they have progression of keratoconus. If you look at the example I showed on the map on the left here, the second column, the one to the right of the blue circle on the bottom, that's the bad D final parameter, and I probably can't read it, I don't think you can, but basically they're all 7 point something. They haven't really changed a huge amount. So the ABCD is much more sensitive and specifically designed for keratoconic progression. The bad display is specifically designed as a screening display for your refractive practice. Now, yes, there's overlap between the two, but this was designed for much more sensitivity to determine progression of keratoconus.
And one of the things, Gairik is not here. He did a very good work of collecting lots of, maybe few thousand eyes over time on the progression. And the work is still on. We built an AI on those patients with multiple parameters. And what's very interesting is, I don't have the data yet because it's still building. The initial AI, which is it's not picking up any of these values, it's picking up virtually everything. The most interesting part is what AI is picking up. You can believe or not believe in AI, is not what we have been known, what we have been studying. It's picking up things on pentacam, those values here, which we have never ever looked at. And it's just picking up. Once it starts building a big database and you feed in the second database, then we'll know whether it's picking up something which is completely noise or something true. So a true AI-based one may actually look at a process which may be completely different from what we've been talking about now. I'm just playing a devil's advocate here, but that is what the future is going to be. If you take the entire data and put it on an AI. Professor Bellin, the last comment on this?
I heard about half your words. The echo on the front row, you're all nodding. The echo on the front row was really difficult. Can you paraphrase it again? I'll try to, or come close, yeah, without the mic.
Any other questions on progression, stability? Oh, yes, ma'am.
Professor
We couldn't understand what you were asking. The echo on the front row was very bad. Can you just ask the question?
No, I asked if there any questions from the audience.
No, but before that, you asked.
No, I was just telling that AI may take all this parameter and is analyzing, and what we got the first look at the AI on progression of close to 1,000 odd patients were looking really surprising. And they were not the parameters what we expected to see. And we are feeding the second 500 and asking the machine if this is again picking up the same trend. So it may be completely different from what all the values we are born with or what we've been seeing.
Yeah, and the one thing I think is even more confusing is how to determine progression after cross-linking. And on the new display, when you indicate you've treated a patient, all those confidence intervals go away. So I don't know how to determine. Maybe Theo does. I don't know how to determine progression after cross-linking.
I have no idea how to do that.
And that's
Now,
Any questions? Yes, please, ma'am.
Professor Bellin, I had a question about when he was talking about artificial intelligence. He was talking about artificial intelligence related indices. I wanted to know how the Pentacam random forest index that you've been working on.
okay. So first, I have artificial intelligence. Just to let you know that. Yeah. I have not been working on that. That's really Renato's work. It incorporates a lot of some of my early work with him. As we talked about yesterday, I'm yet to buy into the real clinical value of biomechanics. I still look at it as a research tool. I think the TBI duplicates a lot. I don't think that anyone has to, at the moment, and hopefully no one from Oculus is here, has to run out and buy any of the biomechanical devices unless you have an academic interest or doing research. But at the moment, I think what most of us have is adequate for our current level of knowledge, which is limited. Is that?
Thank you.
I would just add to that real quickly that that work may end up being wonderful, but it is also right on the edge of what Michael talked about yesterday with the statistics that blow you away. It sounds really good to leave one out and look in the forest and do all of these things, but the fact is most of us don't understand what that means at all, and so it's therefore quite difficult for us to really evaluate that work. And so I would say until it is so definitively clear that you don't have to have multiple complex iterations of statistical analyses to show an impact, then be cautious.
Also, I think the same thing is whenever you read a paper or someone presents that, it has to be cross-validated. In other words, you have a population, and what you'll see very often in studies, they'll say, well, I'm comparing it to A parameter, B parameter, C parameter, and then this is my new D parameter that I've optimized for this population. Well, the A, B, and C parameters, no pun on APC, I'll use something else, not meant to, were never optimized for that specific population. You can't make that comparison. You have to then go get a whole new population to test against, and that's not often what is done.
Right, thank you for those concluding comments.